Just to start on, when we talk about personalized medicine, it is like the new shirt that I want to wear. And when we talk about personalized therapy for osteoarthritis, we need to understand where we are coming from. And essentially, what that means is that the disease pathogenesis of OA is not fully understood. The central hallmark of disease is that it is slow, it is chronic, and shows progressive destruction. The disease, however, has shown that it involves predominantly the bone, cartilage, and the synovium, with a lot of interest lately in the cartilage. And the current treatment options of osteoarthritis vary from pain relief to improvement of function. And therefore, the non-steroidal anti-inflammatory drugs, the intra-articular steroids and hyaluronic acid injections have very little effect on actual structural degradation of the joint, and these patients eventually land up into reconstructive surgery in the form of total knee arthroplasty. So the non-steroidal anti-inflammatory drugs, as I've already said, there is no role of a single agent like paracetamol. The pain relief can happen with drugs like diclofenac to a drug dose of about 150 milligrams per day. And one has to be careful about certain renal parameters which can get damaged and distorted. And this is a very, very interesting graph. And this is basically the reason why the world is talking about targeted strategies for osteoarthritis. So till such time, the cartilage, the joint cartilage, does not show a full thickness volume loss, even to the stage when the cartilage has had a focal thickness loss, one can get the cartilage to regenerate. And that is essentially, basically across the globe, causing scientists to study the mechanisms of damage as well as study the personalized therapies leading to regeneration. And what basically is the hallmark of this period of growth is a branch of medicine called precision medicine, which essentially, as has already been talked about by Dr. Raja and even Professor Majumdar and Dr. Jha alluded to this. One has to identify that osteoarthritis is not the common mechanical degenerative osteoarthritis of the knee or the hip or the hands, but it consists of certain primary and secondary phenotypes. And it consists of certain age-related and systemic and inflammatory phenotypes, certain intra-articular and extra-articular phenotypes. And what these phenotypes do, and that, as Dr. Jha was just talking to us about, is that the window of opportunity opens up essentially because each one of these phenotypes have a quantifiable measure of certain very specific neurochemicals in the synovial fluid, in the blood, or in the urine. And that is the reason and the focus of where and how targeted therapies can be accommodated and can be focused upon. To an extent that people have actually come out with something which is called a B-score, which is like equivalent to a T-score of a DEXA scan, which is used for quantifying the degree of osteoporosis. So the degree of targeted therapy or stratification of drug therapy for osteoarthritis also, according to certain scientists, can be focused and scored. Now, what should precision medicine include? Essentially, it should include identification of the basis for personalization, a reduction of risk factors, targeted therapies, and personalized realignment procedures. And the bulk of these drugs essentially cause prevention of cartilage breakdown and promotion of cartilage repair. They are targeted at the synovial inflammation in osteoarthritis, as has already been discussed beautifully, and they are targeted at the subchondral bone remodeling in osteoarthritis. So a lot is being done just basically to make sure that we do not land up into the end stage disease treatment in the form of arthroplasty or realignment osteotomies, but for certain targeted therapies. And one of the most important ones of these are the metallic metalloprotease inhibitors. And these MMPs, as we understand, are essentially drugs, are essentially chemicals which are present in the articulochondrocytes. The beauty of MMPs is that it has a dual role in the joint. It is involved in pathological destruction of tissue as well as in remodeling and repair. And the drugs which are focused at inhibition of MMPs actually not only cause a stoppage of the pathological destruction, but also sometimes can play around with the repair function of these MMPs. And there has been a beautiful trial, and the most talked about drug, PG116800, a matrix metalloproteinase inhibitor. What has come to light about this drug following a 1-year dose response study is that after the usage of the pre-described dose of this study, there has been no change in the joint space narrowing or the functional outcome scores in patients of osteoarthritic study, as said a double-blind placebo-controlled trial. Coming to bisphosphonates, well, the focus of these drugs is in working on the loss of structural integrity in the subchondral bone compartment. And these are anti-resorptive drugs, which essentially are osteoclastic inhibiting factors. And most of the studies has been done on risedronate through 2 fantastic trials. One of them is a COSTARS trial, but both these trials, after a 1 and a 2 years follow-up, has shown that at all doses of risedronate, there has been absolutely no improvement in the functional outcome scores, and the drug did not radiographically prevent disease progression. Coming to cytokine inhibitors, there are various types of cytokines, as Professor Jha also beautifully alluded to, and these are expressed by cartilage and by the surrounding tissue and have a major role to play in the development of osteoarthritis. So starting from interleukin-1 to interleukin-17, as Sir very nicely told us, there are numerous drugs which have been known, and through numerous pathways including TIMPs and NOS, which have been studied and worked on to see if they actually help in any kind of stoppage of the progression of osteoarthritis. Calcitonin, a drug with a 3-decade of usage for osteoporosis, has been recently reported to have been studied on the cartilage component of osteoarthritis. And this drug essentially has been studied in a phase 3 placebo-controlled trial and has been shown not to have too good an effect on the progression of disease or its ability to prevent the radiographic progression of the disease. There are other drugs such as HCT12 3012, which is essentially a derivative of naproxen and has been known basically as a COX-2 inhibiting drug working through the nitric oxide pathway. But this too has, despite certain trials, is in development and has not shown any confirmed positive role in the inhibition of progression of osteoarthritis by drug therapy. Coming to doxycycline, an antibiotic, which was worked on, and there have been a study on 431 women, and was reported that the joint space narrowing was reduced in obese women by 33% after 30 months of treatment. But this particular study was a relatively small sample size with a very small follow-up, and this drug could not be recommended as a chondroprotective drug, despite the good results of this particular study. Coming to drugs like diserine and glucosamine. So these drugs have recently had a renewed interest following certain additional roles. And these were essentially drugs which were interleukin-1 inhibitors. And essentially what has been observed is that even though there was a statistically significant benefit of these drugs on cartilage degradation and damage, the ultimate role in protection of disease and progression of disease has not been documented and has not been strongly verified. Coming to cell-based therapies, so that is a focus of a lot of research as of today. And the basic stem cells which have been focused on for the research is mesenchymal stem cells, embryonic stem cells, pluripotent stem cells, and the adult stem cells. But what has been observed is that all cell-based therapies which have been used for treatment of osteoarthritis lack standardization with respect to the qualitative and the quantitative characterization of the methods used for cell harvesting, processing, and transplantation of the cell back to the source, which is the patient. And thus, the well-conducted randomized clinical trials, despite their very well thought of research methodology, have been found to be inconclusive, particularly in their ability to demonstrate efficacy with disease-modifying results. So in the end, we come back to what we understand and know, and the take-home is that if you study the osteoarthritis patterns of hip, knee, and the hand, what we know very strongly is that there are certain established therapies which are basically very well known for prevention of pain induced by the osteoarthritis, and certain physical therapies which help in preventing or delaying the progression of disease. But if you see there has been a lot of focus and emphasis on research on the new medical and the therapeutic drug modalities involved in osteoarthritis, but their actual role in progression of disease and protection and prevention of radiographic progression of disease is still to be verified, and it is still to reach a point where they can become a standard of care for patients of osteoarthritis. So thank you for your time.